So, dear colleagues, dear friends, welcome to this satellite symposium, Challenges in Cataract Surgery and Advanced Technology IOL Solutions, which is being sponsored by Rayner. And we have a very distinguished panel. We're still missing one of the speakers, but that's not a problem because he'll come a little later. We have Allon Barsam here from the UK. We have Başak Bostanci here from Turkey and Tiago Ferreira from Portugal. And then we'll also have Gerd Auffarth from Germany, who will be joining us in a few minutes, I guess. I think we'll just get started because we have a lot we want to cover in short time. So we'll start with Allon. It's the benefits of increasing depth of focus with advanced technology IOLs. Allon.
Thank you very much for that introduction and to Rayner for inviting me to speak. These are my disclosures. I do consult for Rayner. So I'm going to talk to you a little bit about the Ray 1 IOL platform. I'll talk about some elements of Ray 1 trifocal optic technology. I have a case report, which is just a general challenging case that could potentially confront any of you with any lens you're using, which hopefully will be of educational benefit. And then I'm going to speak a little bit about the Ray 1 EMV and then share my recent experience with the Ray 1 EMV toric. So one of the nice things about Rayner lenses is that they all come on one totally preloaded injector platform. The injector platform is very straightforward to use. So your nurses can be taught within a few minutes how to use it. It's quite foolproof, which is very helpful when you're trying to move through cases at volume. There's a lot of peer review evidence on the benefits of the Ray 1 trifocal in particular. I'm not going to talk about them now, but I will talk about some of the elements of the optic design which make it my trifocal lens of choice when I use a trifocal. One of them is that it's aberration neutral, so it doesn't induce any additional spherical aberration, which means that it's shown to be relatively tolerable for small amounts of decentration or tilt. It has fewer rings on the optic surface, so many of the other trifocals have, I think, some of them have 25 rings. This one only has 16 diffractive steps, and that's in a 4.5 millimeter zone. Outside of that zone is just distance. And that means that there's very high percentage light transmission to the retina. Most of it is allocated for distance, and the rest being split evenly between intermediate and near. So this is a case, 70-year-old patient, did a Ray 1 trifocal, and 3 months post-op started to complain of dysphotopsia, quality of vision issues, vision reduced, unhappy, and he wanted to maintain spectacle independence. So this is the video. It's a bit of capsular phimosis, there's capsule fibrosis. I'm using a 30-gauge needle here on viscoat to try and dissect and free up the capsule. It's actually quite easy to dissect over the haptics of the Rayner lenses if you need to. But difficult to get access when the capsular excess is small. That's what the challenge of this case is. You can see how decentered the lens is, so the Purkinje reflex there is well outside of the central distance part. So I'm hoping I can kind of create a new capsular excess. I'm using the MST microforceps here. It doesn't go very well, so you can see I grab it and then the whole thing tears right out to the equator. And these cases are much, when it's an advanced technology patient, the stress levels are much higher because the expectation of good vision is higher and the problems of having a decentered lens are greater. So I'm freeing up the haptic here. It's worth saying this is the only time I've confronted this problem with a Rayner lens, and I've put in about 5,000, so it is very unusual. But nonetheless, you can get decentered lenses and you can get capsular phimosis. Obviously, it's important to make sure that both haptics are free. And then when you've got an anterior capsular tear, which essentially I've created and you do have here, it's nice to move the haptics away from that area so that there's no risk of iris chafing or anything prolapsing out of the bag. But you can see here the compressive force that was applied when it was phimosed between the haptic and the optic is still present. So although it looks much more centered now, I'm using a bimanual technique here to move the haptic away from the optic into its more anatomical position, and then this centers really nicely. So that concludes that case. And afterwards, did very well. Visual acuity was 6/6, N5, and again, regained spectacle independence and satisfied. So there are some patients who basically want to be spectacle independent, but you feel would be have a low tolerance or intolerable of things like halos. And that's really where I think Ray1 EMV comes into play. If you target just distance vision, then you get good distance vision. It behaves very much like a monofocal lens, but it also gives you a bit of intermediate vision. And if you target some monovision, then you can also have them read unaided. I was the first surgeon in the world to use the Ray1 EMV back in the middle of COVID, in July 2020. And we've published and presented these results quite extensively before. But essentially, we started off just with an emmetropia target to see how the lens would work. And it performs well, gives you intermediate vision, and only sometimes do they actually see well for reading. But if you target true monovision, which I did in this case, this just shows you the aberration, so it's mostly spherical aberration is how it's working. But here we targeted minus 1.25 in the right non-dominant eye and plano in the dominant eye, and the patient is able to see 6/4 and N4 unaided. So the newest addition to the Rayner family is the Ray1 EMV toric, which has literally just been launched here at ESCRS. Basically has, like the Ray1 EMV, it gives about 1.5 diopters of increased depth of focus if you target emmetropia, and then more if you target myopia. It gives very natural type vision. There's no diffractive optics. Patients don't complain of reduced contrast. There's no halo at all. And it is optimized for monovision, so you can use it for some level of monovision in order to make patients more spectacle independent. The Ray1 EMV comes from +10 to +30 in half diopter increments, and this lens to start off with will be +10 to +25 at half diopter increments, and then have almost a full range of cylinders, so up to 4.5 diopters of cylinder in the IOL plane. So this is the case. I did this operation just 4 days ago on Thursday. I was one of 2 or 3 first implanters of this. It just got CE marked approved last Monday, so just 6 days ago. This patient came to me, actually, he's a refractive patient, so no cataract. And what I like about presenting these patients as cases is that they are basically totally driven by what the optical performance of the lens can do. They're not just satisfied because you've taken the cataract out. It's really what the lens can do. So the lens has to perform in some ways similar to how you might expect laser vision correction to perform in order for them to be satisfied. And it's a good test of, is the lens doing what you want? So here's a hyperope and a presbyope, and he has a little bit of a refractive astigmatism. The right eye is his dominant eye, and the left eye is his non-dominant eye. This is the corneal topography. So the right eye has 0.9 diopters of against the rule astigmatism. The left eye has 0.6 diopters of against the rule astigmatism. What I found with the EMV lens is that it is relatively intolerant to astigmatism. So I view it a little bit like you would view a trifocal in terms of how aggressively you need to manage the astigmatism. So why I'm excited about the Ray1 EMV toric, because it gets around that problem. In the left eye with only 0.6 diopters, there was no need for a toric version of the lens. And I just targeted, I used a 26.5 diopter lens in the left non-dominant eye, targeting minus 0.68. So I pretty much always now aim between -0.5 and -1, depending on how much spectacle independence I want. And then I target the lowest positive number or 0 in the dominant eye. So now the Ray1 EMV toric is part of the normal Rayner platform, so you just use their normal online calculator, put in the K values, from the biometry and the axial length, and it will tell you which lens to use. I'm using the Hazard Optics instruments. I'm not sure if you're familiar with them. They are a very innovative maker of disposable, beautiful micro instruments. So I use a Callisto here with the heads-up display just to make sure I can align the lens well. It goes through, this is a 2.2 millimeter incision. It would go through on a wound assist on 2.2, but you'll see me later, I like to enlarge a tiny bit. These are the Hazard Optics capsular exis forceps. And when you're using advanced technology lenses, it's not essential to have a well-centered, round, well-sized capsular exis, but it is nice. I think it does give a slightly greater level of precision, and so the instruments you're using are important. The chopper here is also helpful for hydrodelineating this soft lens. It is a refractive lens exchange. And the rest of the case really proceeds without anything of note. So here you see the injector system. Again, I'd like to enlarge just because it gives me a little bit more control, but I'm still using a wound assist. A little bit of viscoelastic here into the chamber. Clicks shut. roll, so bevel's facing down, a one-handed technique, so you can use your non-dominant hand to counterfixate the eye, comfortable for the patient under topical anesthesia. Lens goes easily into the bag, and then they've changed their toric alignment markers now on the lens Rayner. So they use, I think, a YAG laser, makes it very clear and easy to see. And it just lines up now. And you can see like the capsular rectus is how you'd want it to be. The alignment is good. We don't have, I don't have post-operative refractive data to show you because I only did the surgery on Thursday. But he was very happy on the first post-operative day after this. So I will be able to show you data eventually. There's a few early adopters of this technology, so we'll have data to show you by the end of the year. So in conclusion, I've shown you some information on the Ray 1 platform, the advantages of anti-vaulting haptic technologies. You saw when I rotated that decentered lens, it stayed in the bag nicely, it didn't kind of try and prolapse forwards. The EMV offers range of vision, helps them achieve spectacle independence without compromise on quality of vision. And now the toric gives us the opportunity to also eliminate astigmatism, the Ray 1 EMV toric. I think we may have time for one or two questions. Thank you for your attention.
Have a seat, have a seat. Yes, I have the one or other question. First of all, you said, and that sort of made me a little confused, but you may be right. You said that you had the feeling that the EMV lens was less tolerant to astigmatism than what you usually have. Because my thinking was, sort of, let me say, EDOF, monofocal plus, that kind of category. We don't exactly know what is EDOF and where does monofocal plus end or where does EDOF start. But if, taking that out, my thinking was always it was a little more tolerant to astigmatism than, for example, a trifocal. But it may be even also sometimes than a monofocal. So do you have data for that, or is it just a personal impression, let me say it that way? Or is it just the patients are more, they want more and they're asking for more, and you just have to be, because they have wishes which maybe the usual patient may not have?
Thank you. That's a good question. I didn't plant the question, but I am glad that you've asked it, just because about a third of my entire refractive practice works by the deliberate induction of spherical aberration. So the answer to that question came from my laser refractive practice. So I used Presbymax, which induces negative spherical aberration, and I just found that post-operatively, they weren't as tolerant to astigmatism as you might expect. And I see the same thing with the Ray 1 EMV non-toric. And my thinking is that, and again, nothing's been published on this, because the mathematics of spherical aberration and coma have been well worked out, but how spherical aberration corresponds to refractive real-world, let's say, defocus, and how coma might correspond to refractive real-world cylindrical correction hasn't been well worked out. And my feeling is that if you induce spherical aberration deliberately, then they do not tolerate coma or cylinder, if you like, as the two might relate to each other. So it is really important to actively correct for that. That's why I think there's that correlation. But it's something that if there was, someone wanting to do a PhD on, I think there'd be a lot of information that you could gain.
It sounds like more than one PhD, yeah. To me. Another question is, you showed the case with the decentered lens, which is actually quite rare, I must say. You also said it was rare with that platform. I've hardly ever seen that. What would your strategy have been if the tear would have gone onto the posterior capsule as well, which it didn't?
Yeah, I mean, the more cases of lens repositioning and lens exchange I do, the more my feeling is that if things aren't going well or aren't going as expected or something like that happens, then I've never regretted putting in a three-piece spherical lens. And there are so many things that you hear people present, oh, why don't you capture the optic, put it into the vitreous cavity? And I've tried almost everything. And it can work amazingly well, and then you feel heroic, and the patient does great. But the chances of having problems in that kind of scenario are high. And what I think takes a little bit of the heat out of the situation is counseling the patient before the operation. So I never say to the patient, oh, just got this small problem, I'm just going to bring you back to the operating room and take care of it for you. I say, look, this is really rare, and I'm confident that it's going to go well, but there is a chance that it's going to be really problematic, and then I'm going to have to take the lens out. And I sometimes even tell them I might not put a lens in. If it really goes badly, I might decide to revisit, put it in as a secondary procedure. But in general terms, a three-piece intraocular lens, if you're in trouble like that, works fine. They don't get spectacle independence, but he could potentially have monovision. There are other options. Absolutely.
And then one last, because we still have a little time, the marks. So I saw the marks are significantly better visualized than the classical, let me say, just line. So that at least on the video it looked really good.
Yeah, I mean, I don't know, there's a few people here from Rayner, but I think that Rayner are quite modest with some of the innovating they do. So they kind of do it and kind of like gently roll it out without making a big fanfare about it. But they are constantly trying to improve a lot of the stuff that they do. And many people probably don't know that the toric lens that they might have seen 2 years ago has now been much improved, even for the monofocal.
Yeah. Okay, thank you very much, Başak. We'll continue now. Again, advanced technology IOLs, but now for patients with challenging corneas. Başak.
Thank you so much. Thank you for being with us tonight. Thank you so much. So today I'm going to be talking about advanced technology lenses for patients with challenging corneas. Here's my disclaimer with my financial disclosure. So go ahead and imagine this patient, a 67-year-old retired teacher who doesn't drive at all, with no systemic or ocular disease, with no history of refractive surgery, with a good ocular surface, who is seeking for spectacle independence. Life is good here. You have many options to increase range of vision. You can go ahead, implant a trifocal lens. You can either implant the trifocal in the sulcus and do a DUET procedure. You can try your chance with EDOF lenses, do a monovision here, and you can try to do a full, moderate, or mini monovision for this patient. But now imagine this patient, a 68-year-old dentist who loves nighttime driving, with a history of refractive surgery, with dryness, who is using drops when he wants, and when he doesn't want, he doesn't put any. He insists that he doesn't want to use any glasses for most of the day. Would you be confident enough to go ahead and put a trifocal lens with a diffractive technology? There are many advantages of monofocal lenses. They are suitable for any eye, with ocular surface problems, glaucomas, retinopathies, amblyopia, astigmatism. They are good to be implanted for most pupil diameters. Usually, they create no severe halo or glare, and they're cost-effective for many patients. But there is a compromise in functional vision, the vision we need when we are cooking for our patient, not patients, our parents, our children. When we are driving, when we are checking the panel, we need functional vision. We need intermediate arm length distance. So our monofocal is the only option for patients with a history of corneal refractive surgery, patients with severe dry eye, and ocular surface disorders. Here's what I do for my challenging cases. I prefer to implant a Ray 1 EMV, which offers an extended depth of vision with a non-diffractive optic technology, which is optimized for monovision. Starting with case 1. So my first case is a dentist who had cataracts and doesn't want to wear glasses in his social life. He rides a motorcycle, mainly at night, and he had a previous suprachoroidal treatment. We all know that the effects of suprachoroidal treatment washed out after some time, but here in the topography, you can easily see that there is a slight irregularity and steepening in the center. So I went ahead and measured the corneal spherical aberrations, and as you may see, it was negative in the right eye and positive, slightly positive in the left eye. So I planned a micro monovision here and left the non-dominant eye slightly myopic in the right eye. So the results was very satisfactory. He had 20/20 vision, uncorrected visual acuity. In the right eye, because of the slight myopia, he had 0.8 decimal vision. Intermediate near vision was Gerd 2. He was spectrally independent for far and intermediate. He doesn't complain about dysphotopsia when he's riding the motorcycle, but he uses surgical loops only while working. One important thing to highlight here is the printouts. So if you are playing with some advanced technology IOLs, if you're implanting them, do not trust your autorefractometer printouts because they will be mistaking you. This patient shows a little myopia in the printouts because of the positive spherical aberration just in the center of the EMV lens. But actually, he is like half diopters of myopic in the right eye and a metropic in the left eye. The second case, a retired female teacher with cataracts in both eyes with a history of post-hyperopic LASIK. And the thing here is she is giving the decision to me to pick lenses for her, which is very challenging for cases. So what happens after hyperopic LASIK is you are inducing a little negative spherical aberration. So I thought to myself, if I will choose a diffractive lens with a negative spherical aberration, this will make the spherical aberration a little more negative than the optimal. So I measured the corneal spherical aberrations and saw that it was negative in the right eye and neutral in the left eye. So I told to myself, luckily, she was a metropic in the right eye. So if I put a lens with central positive spheric aberration in both eyes, maybe I will correct the corneal spheric aberration in the right eye, giving the chance to have very clear vision for far. And for the left eye, maybe with the help of some myopia, I will give her some intermediate vision. So this is what happened.
Şimdi karşıya okutuyorum. Şöyle okuyalım.
D-H T-A-C.
Harika.
Maybe we can increase the volume a little.
V-A-R.
So she has bilateral 20/20 vision. And for near,
Şimdi yakın okumanızı isteyeceğim.
this is
Şu C
35 centimeters.
başlayalım.
C-B.
Altı.
D-L-N.
6.
P-R-E-R.
Şurası var mı?
F-Z.
So for near, she can read Jagertri, which is very satisfactory for a EDOF lens like this.
F-G.
And she says when she wants to read for long time, she's wearing +1 glasses, over-the-counter glasses. So the third case is a female with Sjögren's syndrome and cataracts with 0 Schirmer scores. She received lacrimal plugs, she has been on cyclosporin for 10 years, and wants spectacle independency at home. And, you know, she's not an ideal candidate for a diffractive trifocal for me, because I feel like sometimes she is using short drops, sometimes she forgets to. So if I take the medicine from her, she will be lost with a diffractive optic because of the dryness. This is how she looks like in the first visit. Without any doubt, you have to take care of this dryness, this punctual staining, otherwise you will be mistaken by your biometric measurements. I planned minimonovision for her. Her spherical aberrations were surprisingly negative. So now,
Baba burnu Asya'nın en batı ucudur. Sadece insan üzülünce gözyaşı döker.
she's not wearing any glasses.
Türkçe sözcük vardır.
Maybe her pupil size is very small. We don't know. She doesn't wear at all.
Mahkeme ilanı yazısı bu boydadır. Bunu okuyorsanız ne mutlu size.
Jager 1
Ne
for
mutlu
near.
size.
And this is far.
Evet, ne dediniz az önce?
H, F, Z.
20/20 for far. These are, you know, special cases, you know. She's very happy. And my last case is a 50-year-old woman with diffuse corneal opacities. I did a phaco for the left eye 1 year ago with a monofocal hydrophobic lens, and her best corrected visual acuity is 0.4. Now she's there with cataracts in the right eye and asked whether there can be a premium option for this eye. This was a little jeopardy. I, again, measured the corneal spherical aberrations. It was a little positive, but less than 0.1. So I discussed with the patient that there must be, you know, we may not get any intermediate vision, but we will give it a chance. The thing I like about EMV is we are always discussing the PCO rates about hydrophobic lenses, but we are not discussing the advantages of hydrophilic lenses too much, I think. Because it is hydrophilic, the refractive index is lower compared to hydrophobic lenses, which makes the MTA scores a little higher, giving a clearer image to the patients. And hydrophilic lenses are resistant to fibrin and protein deposits, which is especially important in eyes that are prone to inflammation. And what I like about EMV lens is the preloaded injector, which enables you to implant this lens through incisions that are smaller than 1.8 millimeters and offers you a very stable platform in each case. So this is really a standard cataract case. Let me show you the implantation. I don't feel confident doing wound-assisted, but I'm not enlarging it. It enables you to do a smooth implantation. And the one thing we are afraid in hydrophilic lenses is the lens can open very quickly. Here it doesn't happen. It is opened in a very controlled manner. And this is post-op 1 week. Let's see.
Hanımcığım. P'den başlayayım mı yine?
Olayım.
P, T, E, R, F, Z, B, O, E. Alttaki nokta.
I'm mumbling. Oh, I'm very happy with your results.
Ötekini de şey...
And this is how she sees far.
Kare ne? Onu okuyorum. O rahat. Burada P değil, D olabilir mi?
Evet.
D.
The thing about those patients are, these are very special cases. The key here is making the patient satisfied, not giving 20/20 vision. So in my experience, Ray 1 EMV performs satisfactory in those challenging cases. And we must not forget to always treat the pathology first. I aim at metropia or micromonovision in these challenging corneas, but I always try to set realistic expectations and promise less and deliver more in those patients. Thank you for listening to me.
Thank you, Başak. If it's okay with you, we'll continue and then discuss that later. Very nice cases. So now we'll have Tiago Ferreira from Portugal, and he's going to talk about essentially considering different technologies and the dysphotopsia profiles. Tiago?
Thank you very much. Thank you to Rayner for the invitation to be here. So we know we have several options to correct presbyopia, several kinds of IOLs, and sometimes the selection of these IOLs is not easy for us. The level of spectacle independence and dysphotopsia depends on several factors which are identified, namely on IOL platform design, for example, the centration, stability, optic design, refractive index, or dioptric power. The IOL optic design, the amount of focal points, additions, the technology of the IOL, and the surgeon's technique and troubleshooting solutions, also on patient's ocular anatomy and expectations. So the Ray-1 trifocal for me is for a patient that demands total spectral independence, but of course is able to tolerate some level of dysphotopsia. What I'll show you is the investigation we've been doing with this lens and with the EMV lens. So this was the first paper we published in 2019 with the Ray-1 trifocal. We compared the lens with the fine vision, PODEF. And here are the main differences between the lenses. Allon talked about this. The Ray-1 trifocal has a very low loss of light. Also is aberration neutral. And this was a double-arm randomized prospective case series of patients submitted to cataract surgery, 13 eyes of 15 patients, and the evaluation we'll see was done with the McAllen Quality of Vision Questionnaire. These are the results of the visual results. We can see they're similar, but for intermediate vision between 80 centimeters and 2 meters, there is a slight advantage for the Ray-1 IOL. These are the dysphotopsia results. They were similar in all cases, except for depth perception, and depth perception was less frequent and less severe with the Ray-1 than with the fine vision. Halos and glare were the most common visual effects identified by patients, but fewer patients with the Ray-1 identified these symptoms. There is also a trend for double vision distortion and depth perception to be less bothersome in the Ray-1 trifocal patients. These were the differences we found. What can this mean? Maybe at driving at night, it may have some importance. That we know that depth perception is important in this context. Sorry. Then we compared it with another IOL as well. We introduced here the panoptics. The other two groups had the same lenses. And again, here the differences. We can see the main difference is the aberration correction is different in the three IOLs. And this was the same kind of study, the same kind of design, triple arm, randomized, and prospective. The evaluation of dysphotopsia was the same. And here are the visual results. They are similar to the previous study. The Rayner trifocal is better for intermediate vision, and the panoptics as well is very similar to the Rayner 1 trifocal. These are the dysphotopsia results. Again, we found the same, more severe depth perception issues in the PODF group than in the Ray 1 group. And then the Ray 1 EMV. The Ray 1 EMV for me is for a patient who doesn't want or doesn't tolerate dysphotopsia, but also doesn't require total spectral independence. So the study we did was comparing this with five different IOLs, a monofocal IOL, the Technis 1, the Ray 1 EMV, another enhanced monofocal IOL, which is the Technis Enhanced, and then we used two EDOF lenses, the Technis Symphony and the Vivity from Allon. Again, prospective comparison, randomized, 30 patients in, sorry, this is not randomized, prospective comparative, 30 patients in each of the groups. These are the defocus curves, where you see the gray shaded area. There were significant differences between the lens, with the Technis 1 losing vision from minus 0.5 diopters up to -3 diopters. The other lenses were much better. And as you can see, the Ray 1 EMV is almost comparable to the EDOF lenses. And this is not using monovision. This is with emetropia on both eyes. The photic phenomena were similar in all the groups, except in the Symphony group, of course, because it's a diffractive lens. So here there was a significant difference in the visual symptoms. When we asked the patients how often they wear the glasses, these are the results. So for the high-ends, 26%, and then very similar for the Symphony, for the Ray 1 EMV, and for the Vivity, around 60 to 70% of patients never or almost never wear glasses. So in conclusion, the Ray 1 trifocal and the Ray 1 EMV provided excellent distance and intermediate visual acuities. The Ray 1 EMV had better intermediate vision than a standard monofocal IOL, and a similar range of focus to the other lenses we studied. The Ray 1 EMV showed also a high degree of spectral independence, and the Ray 1 trifocal, of course, showed a higher degree of spectral independence for near. Both the Ray 1 trifocal and the Ray 1 EMVs offered a low prevalence of photic phenomena. Thank you very much.
Thank you very much. I think we should take a few minutes to discuss among each other, discuss about, when do we use a trifocal, when do we use EDOF / monofocal plus, this old story, where does it start, where does it end? And so I'd like to sort of ask each one of you, maybe I'll start with you, Allon, because you're right next to me. So what is the criteria for you now? Obviously, a patient who wants a lot of near vision, very good near vision, well, then that's one thing. But a patient who says, you tell me what I should do, and I'll be happy. I would like to not need reading glasses all the time, but once in a while is okay. So how do you go about that?
Yeah, so those more kind of, I would say, laid-back patients, but that would want to be spectacle independent, I would always go to the Ray 1 EMV, because I feel that if you were to use a trifocal and they were then to be dissatisfied with quality of vision, they would always go back and say, well, actually, I didn't mind if I had to wear glasses for small print reading. And I think sometimes we think too much about whether it's really important for patients to never, ever need glasses for anything. Whereas if you can make a patient spectacle independent for 95% of their tasks, they're normally very satisfied. So if they did have to read some contract or something really small and the light levels weren't good, and they put on a pair of just off-the-shelf +1 readers, that doesn't bother them. They're doing that like twice a week for an hour. But for all their day-to-day, their phone, their computer screen, the dashboard of the car, the menu in a restaurant, you can make them independent with all of that. And the key thing, without giving them any halo. I mean, that's the thing. The thing about halo is interesting because it was interesting to look at those Vivity results, because the Vivity gives every patient a halo, but it's mild, it doesn't tend to really bother them. But you just mention it to the patient, you're going to get a halo afterwards, and you can see their face just going, what do you mean I'm going to get a halo? They don't like the idea of anything that's going to mess with their vision, if you like. And then with the trifocal, even more so. So I think a huge advantage of the EMV is that basically 0 halos.
Başak?
I completely agree with Allon. So what I do is I only implant trifocal lenses in eyes with a perfect ocular anatomy and physiology. If there's any compromise, if the patient has any glaucomatous, or retinopathies because of diabetes and stuff, without any hesitation, I go ahead and implant an EMV. But if the patient is very, insistent about not using any glasses for reading, and he has a very good ocular anatomy and physiology, I only implant trifocal lenses. Because there's always a slight chance that in 10 years' time, there can be slight changes in the retina and so on. So I think as ophthalmologists, we shouldn't be very confident to go ahead and implant trifocals in everyone. I think the trifocal rate shouldn't exceed like 20% of your cataract patients.
Well, because we actually see in the ESCRS survey where we ask our members, about the practice patterns, and we do that every year. We usually have 1,300, 1,400 respondents. So I think it's in a pretty good, showing of what's actually happening. We see that the trifocal is getting a little less, and we're seeing a great expansion of EDOF, and also, of course, a new monofocal plus or enhanced monofocal segment is also, enlarging. So do you see that in your practice? Do you see less trifocals now than you maybe did 3-4 years ago?
Yeah, absolutely.
Tiago?
I agree. First of all, the trifocal patient is for a patient with a totally normal eye. And we can, with this new enhanced monofocal, provide some advantage in vision for patients with even some non-normal eyes, as we saw. So that's an advantage. Then it all depends on what the patient wants. If the patient tells me he doesn't bother to wear glasses sometimes for reading or for prolonged reading or for small letters, then I think about an enhanced monofocal, about the EMV, which, as we saw, sometimes we prescribe the glasses and patients don't even wear them.
But I'll ask you now, do you also then always combine it with some monovision? Do you always do a little monovision?
I'm still not doing a monovision.
Just distance?
Just distance. Even so, they don't wear glasses.
But the lens, which is a little in the minus? Or do you even
a little in the minus,
okay.
Yes. It's the first minus, usually.
Yeah.
And trifocal is just for a patient who wants total spectacle independence. But as you say, it's going down.
Burkhard? Oh, sorry. Gerd.
Yeah, thank you. I think when the trifocals were introduced, we appreciated the new gain in intermediate vision. That was a difference from the bifocals. Now we have so many lenses reaching out to intermediate. That is one of the reasons why we don't need the trifocals so much like we used them before. And really, the hardcore reader, you can only guarantee and satisfy with a trifocal lens. There's no other way. But he has the expense of the dysphotopsia. And with the combination of monovision and the EMV, we're really attacking that area now. And it's more or less the patient preferences and the personality that would lead me in one case to say, I give you a trifocal lens, and in the other case, I think you're better off with this combination.
Yeah, but you, if you use the EMV, for example, you will do a little monovision.
Yeah. I go
half
up
a
to 1
diopter,
diopter.
0.75? Oh, 1. Okay, so really
yeah.
go for it.
Yeah.
But what about, so I heard Tiago is not doing monovision, or just, not routinely, let me say it, with the EMV. What about you, Başak?
If the patient has good eyes, both eyes, I will do like 3 quarters of monovision.
Okay, 0.75.
Yeah, 0.75. Okay. But if there's a compromise in cornea, or if there's a better eye, I go stay, like a metropic.
Allon?
Yeah, I mean, it depends why they're coming and what they want to achieve. If they come wanting a trifocal and I decide that's not good for them, they want total spectacle independence, and I'll push more minus. But if they kind of don't really mind very much, then a bit less. So it's roughly between -0.5 and -1.
Okay.
I rarely go above -1 unless they're already in a contact lens trial. So if some patients are in contact lens monovision, like the one I presented, he was already wearing -1.5 target in the non-dominant eye. But monovision, one of the nice things about it, which you don't have with a trifocal, is that it's reversible. So if they're having night vision problems, they can just put glasses on that they keep in the glove box of the car. If a patient has night vision problems with the trifocal, then they can't drive. Because,
Graham Barrett, who sort of devised this lens, the idea was to obviously combine it with monovision, because that's what he's always loved to do. So obviously it's quite interesting, because 0.75, maybe 1, then none. So we're using it in different ways, which is fine. But I'm just wondering, so I use it with half a diopter 2.75, because I think if you start giving them 1 or 1.25, real monovision, patients, at least in Vienna, they get a little, they don't like the idea, even though they actually tolerate it pretty well in most of the cases. And I think if I do half a diopter, I don't even tell them about it. So I just tell them, you're going to get a lens which will give you a little extra. I do half a diopter if I achieve it, let's see, and I don't tell them. So what may happen is they say, this eye is not quite as good at a distance, and then I just do the reading test and show them one eye, then they, that's a good eye for near, and then they know. So I think that's, the question is, do you really want to talk about monovision beforehand? Because I know that puts a lot of people off. That's my impression. Don't know what it's with you.
I don't like discussing it with patients. If I'm going to give them, like 1 diopter offset, I go ahead and discuss. But if half diopters, no.
Don't even talk about it, yeah. Okay, so Gerd will go for the last talk, and this is now on supplementary IOLs, and it's the question: primary or secondary enhancement solution. Let's see what we can hear.
Yes. Hello, everybody. So when you are now deciding, shall I do an EMV or shall I do a trifocal lens, and you don't know, there's another option that you can have, which may also broaden your possibility. These are the supplementary IOLs from Rayner. These are my disclosures. And I think that's really an innovation, because what I think is innovative here is the term of reversible trifocality. We always have the problem, if we go one way, we have to stick with it. And once you have a trifocal lens in the eye, to take it out of the capsular bag and to put another option in, you have a very small time frame to do that, and it is associated, of course, with some problems. And with the supplementary IOL, we have but much more choices. So for more than almost 15, 20 years now, the Salcoflex in different versions was available, and we used it in Europe at least to work on refractive surprises or to do other use of this. And it really was created to fit in this space behind the iris in the sulcus, and it fits to the underlying optic. And we have done tons of studies that the 2 optical system is as good as a 1 optic system. You all know the Ray 1 trifocal lens, and the same type of trifocal technology is more or less applied to the Salcoflex trifocal lenses with a given near and intermediate edition, with the advantages in terms of reduced photic phenomenon and low independency from pupillary size and so on. And when you do it, we can call it the DUET procedure. So you put a pseudophakic in the capsular bag, a monofocal lens or a monofocal toric lens to compensate for the entire refractive error, and then thus the trifocality comes in with the Salcoflex. And as I said, you have several options. You can do a simultaneous surgery, which I call the simultaneous DUET implantation. In the same surgery, you put in the monofocal lens, and you put also in the trifocal supplementary IOL. Of course, you can do also a sequential DUET implantation. First, you do the monofocal lens or monofocal toric lens, for example, in patients with previous corneal refractive surgery, where you are not 100% sure, will I really hit the target? Then you wait to let it stabilize, and then you can use the Salcoflex trifocal to compensate for the residual refractive error and add the trifocality. Or you have the patient who has undergone cataract surgery a couple of years ago with whatever intraocular lens, and he wants to have so-called upgrade. He has heard from other patients that you can have trifocal lenses, and he also wants to be spectacle independent. Again, you can put the lens in, and it's a very easy procedure, fairly speaking. Let's have a look here. Here we put in actually a trifocal supplementary lens onto Ray 1 toric. So first we put in the lens here, and this is the Rayner lens, which is excellent in terms also of centration and so on. I really have to say that I like the haptic design very much. So once you've done that, you remove the viscoelastic from the posterior capsule and the entire capsule. Then you put the viscoelastic actually in the sulcus, and then you implant the second lens, the Sulcoflex trifocal. Yeah, I remove behind the lens. Still check that the optic is in the right position. Now we put in the viscoelastic in the sulcus. So we need a little bit more viscoelastic. And then this lens comes out. It's very, very soft, very forgiving, and fairly easy to handle. Usually I put it in the horizontal plane with the haptics. This is, for me, the best place to put it. You have to be careful, of course, when you remove the viscoelastic now that the lens still stays in place. But as I said, with the patented haptic design of the Ray 1 toric, I never had any problems of rotation during that procedure. And now we have finished the case. Oops. So this is how it looks then afterwards, in both cases here in this patient. So what we are using is you can use the Ray 1 toric, the aspheric, the hydrophobic version, or any other kind of intraocular lens. You put in the capsular bag, and then the Sulcoflex trifocal, the planar one, if you already covered exactly the emmetropia here, or you can compensate from -3 to +3 any kind of emmetropia in addition to the trifocal optic. Let's look at some cases and let's discuss why we are using this. So I have a 24-year-old patient with a specific cataract here, which is fairly rare, so we have that at the university. So if I have a 24-year-old and I put a lens in the capsular bag, definitely in the next 50 years there will be a lot of changes in terms of astigmatism, in terms even of the refractive outcome. And again, this patient also has type 1 diabetes. He has a very plain retina, there's nothing there, but we don't know what will happen here. So using this concept, I can easily remove at a certain time frame the trifocal supplementary lens, can correct for an error, or can just leave it out if the patient has some issue, for example, with the diabetes, and no harm is done. But he may enjoy 20, 30, 40 years of good vision. So this is how we started. This is the lenses we put in. And he ended up, 2020, with a very, very nice defocus curve here. And this is what a 24-year-old should be able to see anyhow uncorrected if he has normal eyes. We are not talking about presbyopic patients. So this is a quite nice outcome. Let's go for the presbyopic patient here, a 52-year-old female with a high hyperopia. Yeah, it's a different story if it would be myopia, but in a hyperopic patient, about 50, I would start considering refractive lens exchange, actually. And again, here, we did also the same procedure, and we ended up beautifully with binocular and monocular outcome very, very nicely. And even if there is some changes, or with a hyperopic patient, sometimes we have also some IOL calculation problem, it still works. And it also shows you that there's enough space here in the eye. A lot of people ask me, oh, it's hyperopic, can I put additional lens? Of course you can. The normal lens is almost 4 to 5 millimeter thickness. And the artificial lens, of course, only 0.5 millimeter or 1 millimeter. So there's more than enough space in these eyes. Let's look at this patient here. Somebody comes and has already a pseudophakia a couple of years ago. Actually, it was a patient with previous laser vision correction. And one eye was slightly amblyopic, and so he came and he wanted spectral independence. And this is something you can do. 65-year-old, you can just add the Sulcoflex, the supplementary trifocal Sulcoflex. And in his case, he ended up 2025, 2030, very good, and he was happy with this. He had some halo glare here, but still he tolerated that because he was very motivated, he valued the spectral independence much higher than dysphotopsia. Let's look for another patient. Here we have somebody with anisometropia, with suspected maybe slight amblyopia, and high hyperopia. And again, possibility of applying the technology, compensating the refractive error, and then adding the trifocality is a very good option here. And in this case, we really hit the target very nicely in terms of manifest refraction. And this patient had an excellent defocus curve. And you can see here visual acuity above 1.0, 2016, and so on. And here, the dysphotopsia profile was fairly different, actually, and he was not very much bothered. It's quite interesting to see the differences here. What about patients with macular changes? Yeah, so sometimes you have a patient, but you're not sure. This eye is good. Here you see some changes in the Bruch's membrane. You're not quite sure what has happened here. It's not really an AMD patient, but you may not be happy to put in a synergy or something like this. Yeah, so in this case, we applied the same technology here, and we see that the patient after 3 months was not happy. But this was not because of the macular change. It was just because we had a refractive surprise. We ended up -1. Yeah? So the beauty of reversible trifocality is that you either can remove it or you can just replace it. So we replaced the lens, we adapted the 1 diopter minus, and now the patient was extremely happy. And I have never had actually one patient in my study with a visual acuity of 20/10, but this is the only one, frankly speaking. So she really ended up very nicely, which was a good surprise for us. But so you can handle this kind of thing. The other option would have been, if you have a lens inside the capsular bag, to do a femtoLASIK or something with these patients to compensate for this. But then you would induce also some high-order aberrations, and you may have also some problems. So in the publication we just had from the AJO, you see all the indications where we decided this could be a good candidate for reversible trifocality or for the option of this. And as you can see, we had cataract patients, refractive lens patients. And there's also the patient who is just where you don't know if he is accepting dysphotopsia. And these are the average results of these 25 patients. And you can see here the binocular defocus curve is very nice. And this patient and the visual acuity, uncorrected distance, intermediate and near, was on average extremely good. So with the Sulcoflex DUET procedure, we can expand our options. We have the reversibility, we can adapt younger age, high refractive error, morphological changes, and if anything is unsecure, there's still the option of a very easy removal of the lens. You don't even need to enlarge the incision size. When you take the Sulcoflex out, you can almost do it through the initial things. You don't need to cut the lens. It's so soft, you get it out quite nicely. So, thank you very much for your attention.
Thank you. So let me ask you, Gerd, obviously you have 2 lenses in the eye, and we know that from the, the classical monofocal Sulcoflex that was really not an issue, as you said before. Yeah. But of course, if you have a trifocal optic in front of another optic, a monofocal optic, you would expect to have a little more glare, maybe a little more starbursts. So how can you ensure that that's not the case? I mean, I know that you have a very good lab. Have you actually looked at that in a lab? Yeah, we looked in the lab. We published that actually, yeah. And because of the material also, we have almost identical performance between a normal trifocal Rayner lens and the supplementary combination. There was no difference at all. We really tested that because we had the same question. If they have some in the interfaces, some problems, and it definitely is not the case. And this is published, peer-reviewed. Yeah. And what is your experience? Because you said sequential is obviously an option. Let's say you operate a patient today with a monofocal lens, and then after a few weeks, the refraction came out well. He's emmetropic. And then you say, well, now we could add this lens. Let's say after 6 weeks, 8 weeks, that would be an option, right? Or 3 months. Now the patient had, in this case, emmetropic, pretty good vision. And now you're adding, obviously, something where we know it's a compromise. We know that trifocal technology, no matter which manufacturer, it's always a compromise. Because don't you get the reaction sometimes, oops, actually, my vision was better, my distance vision was better, my nighttime vision was better, even though they understand that they have near vision. Isn't that an issue with your patients? No, I didn't have that issue yet, but I had the issue that the patient came and said, I'm already happy with what I have. We don't need to proceed with the next surgery. Right. Yeah. But I didn't have this the other way, like you said. But I have that. If the patient is happy with this, he may come up and say, oh, I'm fine, let's just wait.
Yeah, I come back to you next year if I think I need the near independency. That has happened.
Okay. Yeah, because I mean that's something I always sort of because they come from, many of these come from the cataract arena, right? So they have poor vision, they have glare, they have all these issues, contrast sensitivity issues. Now suddenly, it's good, and then we put something in which is going to reduce to some extent the visual the visual quality. And so I always wonder, obviously, if the patient is not very sensitive to that, then that's fine. But those who are a little more,
yeah, it depends on the patient. Some are just eagerly waiting for the next step. Yeah? And some have no really opinion about that. Yeah. They think, well, the doctor said so, so I let it do. Yeah? But there are patients that are very motivated and they're eagerly waiting. You almost have to calm them down and say, no, we wait until this has, like after laser refractive surgery, you said, no, let's wait 8 weeks or 12 weeks before we do that. I want to have 3 consecutive refractive measurements which are equal, so I can adapt the lens. So sometimes they push and you must be careful not to fulfill that. Yeah.
May I ask the other panelists, do you have experience with a supplementary multifocal lens? Yeah. So it's interesting because I used the old one, which was a refractive multifocal, bifocal, and that was obviously not far from perfect, and we knew that. And I think just a very few patients, and my experience wasn't great. And actually, I haven't also. I've sort of have some resistances to actually trying this out. Do you want to comment on that? Why that may be the case?
Yeah, I can relate to that in a way that we have this technology for long years, and when the first bifocal refractive lens from Rayner came there, that is a different technology. This is and this was not so convincing than the trifocal technology now with a really nice optic. And I can understand that you were kind of hesitant on this. But as I said, there is a beauty of reversibility. You're not really stuck with it. If a patient complains or has some issues, okay, we remove it. And this is really not so difficult to do. I think that's ethically acceptable to offer that and also to do the exchange if possible.
Are there any questions from the auditorium? Oh, there is. Sorry, I didn't see you.
For all the panelists, in the last year, in Argentina, we get one and a half year putting on the EMB. I think is great. And in the last year, almost 70% of my premium procedures is to put it on one EMB in the dominant eye and first treating the non-dominant eye with the trifocal one. Do you have any experience? That's almost right now, all my procedures, 70%.
Okay, so I personally, I can just speak for myself. I don't like this mix and match because you're introducing dysphotopsia to one eye, much less or maybe none to the other eye. I personally don't like that approach. Do you want to comment?
Yeah, I agree with you, Oliver. I generally don't like trifocals in just one eye for the same reason.
Yeah, me neither, because if I'm going to go ahead and put a trifocal, I would like to, enhance the power with the other eye by putting another trifocal. Otherwise, the patient will have halo in any ways. So, but I know that there are many people doing this.
Yeah, the same. Patients compare eyes after the surgery, and that's a problem.
Yeah, I would say it's a very individualized decision. Occasionally, you may have a patient where you mix and match because you think it's appropriate, but it's not really the standard.
And I understand you tell the patients beforehand that they will have some dysphotopsia in the one eye and the other eye will have less. Do you tell them, or you just go ahead? Yeah. So, but you tell them. So they will know that. Okay. Yeah. Okay. Okay. Well, I think what this would need is a good study, proper study.
I mean, what's interesting is that you actually, if you have an unhappy trifocal patient, sometimes when you just take the lens out in one eye, then they're okay. And also, if you have a unilateral cataract in a young patient and you put a trifocal in, often they are okay. So there's clearly going to be many patients that are fine with it, but just for the conceptual reasons that Oliver mentioned, I don't tend to do it routinely.
One more question, yeah?
Yeah, just a question about the markings. It's nice to hear that Rayner has improved the peripheral markings for the toric lens, because that's really a very useful thing, because I have to do a lot of these Rayner torics, and we use them in post-graft patients. So when you've got a peripheral cornea, which is very hazy, it's very difficult to pick up that little mark. But the good news is, obviously, we've shown that enhancement there. My question is, we use the Sulcoflex quite regularly in post-keratoplasty. Have they done that similar sort of improvement to the Sulcoflex platform?
Well, first of all, I don't know. But do you like to use a Sulcoflex toric? Because I have had quite a few patients where it rotated and actually stopped using the toric.
Well, in terms of keratoplasty? In terms of keratoplasty, I've used them regularly for the last 7-8 years.
No, but I mean rotation afterwards. You haven't
rotation, you do get some rotation.
Yeah.
But, I think the flexibility, as the panelists have already mentioned, about using the Sulcoflex, the fact that you can see what the outcome is, and we've had 1 or 2 patients where the rotation has to take place, but on the second occasion, that hasn't been an issue.
Okay.
And I think maybe because the haptics are rather sort of flaccid, and once they firm up a bit, then it's easier then on the second.
Do you use toric Sulcoflexes? I mean, just monofocal, do you use them?
No, I don't. I worry about rotational stability. Yeah. So in a case like that, I would use the Visian ICL if I needed to use a secondary lens.
Başak?
Rotational instability has always been an issue for sulcus toric lens implantation, but from the case studies, I know that actually Rayner products offer better stability compared to many products, but I haven't used any. But it has always been an issue in the literature.
Yes, I agree. I stopped using them. You have rotations and sometimes big rotations.
And they can happen anytime. That's the problem. They don't want to happen in the first few days, but they can happen months later.
So sometimes you reposition them.
Then they go again, I know.
Rotation. So I use the ICL as well.
Yeah. Gerd, also the same impression?
Yeah, the same. Exactly the same, yeah.
I think we're over time already, so I can't take any more questions. Thank you very much to Rayner for offering us to talk about this. And no, we're over time. And you can come up to us, we'll be happy. And wish you all a very nice rest of Milan meeting, and we'll see you in Vienna next year, hopefully.